Well, welcome everyone to Emerging Technologies Workgroup. My name is Ed Hafner. I'm a past board chair of WEDI, also co-chair of the Emerging Technologies Workgroup, or sub-work group. And my co-chairs are Yukish Nasal, Sherry Holmes-Henry, and our new co-chair, Nick Radoff. In each of our sessions, we invite a speaker or speakers to present their solutions with emerging technology. That goes on for about 30 minutes. Then we open up the floor to you to ask questions or give us to impart your observations as well. Today, since we have so many people online, we won't be going audio with you. Just put in your questions or your observations through chat. Please, 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 please feel very comfortable in interacting with us. No question is too dumb. We're here to support each other. Big value prop of WEDI is interacting with people across the industry over multiple stakeholders, with your competitors, with your partners, sharing experiences. It's such a big value proposition to your WEDI membership. So please feel free to interact with us in the chat. Now, today's topic is utilizing AI in the prior authorization process. And before we get to that, I want to let you know we have a bunch of events coming up here. The next one, by the way, for emerging technologies will be on March 20th. We'll be talking about distributed streaming for healthcare ecosystem interoperability. Basically, what we're talking about is adding a full community dimension to point-to-point FHIR APIs. So FHIR APIs are direct with between two partners. How do we open that to an ecosystem? So we'll love to have you there as well. A bunch of events happening within the next month within WEDI. We have an interoperability API spotlight. We have a member position advisory where we formulate our combined consensus opinion and submit that to Office of Civil Rights on their proposed rule to strengthen cybersecurity. So please look at that one to attend. There's a WEDI Winter Forum with a lot of topics on health equity and interoperability. We have cybersecurity challenges coming up. We have Denny and his partners from Massachusetts community sharing their FHIR efforts and what they've been doing with NEHAN 3.0. And something that's formulating that you won't see quite published yet is a spotlight event on AI. So check out wedi.org and click on events. You'll be able to see all this. It's all part of your membership. So please feel free to check it out. As we're all pursuing accomplishing the FHIR prior authorization regulation, many of us are looking at making that process more efficient and more timely. And I was so fortunate to be introduced to GenHealth AI prior authorization solution that really aims to accomplish those goals. And we're lucky to have Ricky Sahu, who's the CEO of GenHealth AI. And I know you have several other people with you, including a customer from Guide Health that will be working with us. So Sahu, I'm going to give you the floor for 30 minutes, and then we'll open it up for conversation.
Yeah, thanks a lot, Ed. Nice to meet you all. I see a bunch of familiar faces on this call, so it's great to see all the friends as well. So as Ed mentioned, I'm Ricky Sahu. I'm the CEO of GenHealth. And prior to this, just by way of background, I also founded a company called OneUp Health, which operates the FHIR API infrastructure for about 70 health plans now. And we spun out GenHealth from OneUp to focus on generative AI in healthcare quite broadly. And what we've really done is we've built what we call a large medical model trained on about 140 million patients worth of claims and clinical data. And we've started to build applications on top of that model, including prior auth automation and analytics. So the reason why the prior auth space is so interesting, and let me share my screen for a second, is definitely because of this new attention to the regulatory state, given how difficult prior authorizations have really made dealing with patient care, with patients getting access to care. There are new regs also around seniors' timeliness to getting access to care. So all of these components are really part of the reason why we are focusing on prior auth today. And yeah, okay, cool. You guys can see my screen. So these new regs have impending deadlines for 2026 and 2027. And I'm assuming most of you all are familiar, but I just wanted to refresh the room for those that might not be. These regs require both API-based access and more timely access to prior auth resolutions. And that, from our understanding, from working with health plans, from working with ACOs and the broader industry, is really not going to be possible unless organizations staff a much bigger team for utilization management, or if you bring AI into the mix. And that's really where we've been focusing, is bringing AI into the mix to help automate these prior auth adjudications without giving kind of the final decision, but providing a recommendation to the utilization management teams so that they can do the final decision. And we'll get into this in more detail, but I just wanted to give you guys kind of a broad sense of how this works. So we basically take in incoming PDFs of patient charts and the medical policies. And those guidelines are, could be the LCDs, and NCDs from CMS, for example, which are all public and laid out rules for what sort of conditions are required before someone would meet a prior authorization adjudication decision as an approval or as a denial. And the way that this works is we simply take in the patient's chart, we take in the medical policy, and I can show you guys how this works. Actually, maybe I'll go through the high level first, and then I'll have Ethan on my team show you guys in more detail. But yeah, basically take in these charts and these policies. We have large language models that are, off the shelf large language models, interact with those, and those can extract relevant parts of the patient's chart, as well as structure the medical guidelines into decision trees. And those decision trees are basically multiple question and answers that are automatically formed by the AIs and are reviewed by humans. So we take those decision trees and we take the patient chart and we instruct the AI to go question by question in that decision tree and find the relevant section of the patient's chart that has the answer to that specific question. So each of those questions gets answered by the information in the patient's chart, and then those answers are basically computed upon by the logic of the decision tree, like this needs to be a yes, that needs to be a no, or this other thing needs to be a no, etc. And by doing that, we're able to basically provide a recommendation decision to the utilization management team that is reviewing that particular case. And we're able to basically automate that in seconds, that behind the scenes AI piece. And then it takes human reviewers a couple minutes to look through that that recommendation on their own, maybe double check some of the answers that might be wrong or that might have lower confidence, and then either agree with or modify the decision from the AI. So we're seeing that this is able to improve the efficiency of utilization management teams by about 75%, and answer the questions of those, of the prior auth decision initially with about 95% accuracy. So there is still, it's not perfect, but it definitely is helping organizations speed up the rate with which they are processing these prior auths well within the time frame that's necessary to meet these new regulations. In addition to the I guess, speed with which these are being able to be answered, we're also able to surface APIs so that you can meet the CMS, requirements in 0057. In addition to our APIs, you can also we're also partnering with various FHIR organizations like OneUp and Smile so that the our prior auth APIs can be fully, FHIR-ified and made available in a more standard, mechanism. So that's really, the approach that we're taking there is really working with the rules that exist as they're laid out in these guidelines. But what we're seeing that AI offers is a much more personalized approach to prior auth. And I know this isn't going to happen overnight, but I want to give you a very clear example of why and how this is helpful. And I think, obviously, in this room, probably full of many people that are from health plans. Like no one is missing the public sentiment around why prior auth is, super important. Why there's so much talk about that today, and that's really because it is impacting, patient care. Um, and what we're seeing is that there are cases where the rules will, effectively say, deny this patient this procedure, and it may be for many different reasons, but those rules are really created by looking at medical research that has often been done only on a few hundred people at a time. And what we're able to do is we're basically able to use what I mentioned earlier, which is our large medical model, to simulate the patient's future with an approval and with a denial. And uh, with those simulations, we can actually understand all of the likely events that are expected to happen to the patient in the future, as well as the total associated cost with that patient's future. And that allows us to do really interesting things. So, of course, the rules exist right now from these guidelines, which is what we are initially following, but we can offer a additional, point of guidance when there are denials that lead to a higher expense for the health plan or the ACO or other organizations. For example, a patient might be denied a service because they missed a lab result by a few points. We can simulate the future with and without that procedure happening. And in certain cases, we see that in the denial, that patient ends up with a high likelihood being admitted to the ER, or with a high likelihood having some other exacerbation of their condition. And then we can add up the total cost of care over the next 6 months, over the next year, and tell you that, hey, actually, you're going to end up paying more for this patient's care if they're denied than if they're approved. And that can lead to a Pareto efficient outcome, which is a win 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 for the health plan, where the health plan can save money, the provider, because the provider can make money on having that service provided, and the patient obviously benefits from that better care and the abatement of those negative conditions or those negative outcomes. So we're not just seeing AI as a mechanism to improve the productivity with large language models, but we're also seeing AI as a mechanism to be more creative and uncovering new insights on how patient care could, be directed. And I think that that's really an exciting future. that this is enabling with the large medical model side of the equation. Before I turn it over to Ethan, who is one of my co-founders, to show you guys and walk you through how this product actually works, I just want to highlight one of the points there. A lot of people ask, like, how explainable are these decisions? They want to be, very clear that yes, this decision that the AI is coming up with has clear rationale, and we can trace that rationale back to the policy and the patient's chart. So what you're seeing here is basically the patient's chart on the left side and the policy on the right side. And effectively, each question is being answered with a citation back to the patient's chart. These answers can be expanded with explanations that are written in there. But this is not something that we've really seen out there. It's not really something that has been done with this level of fidelity. And it is something that we have now in practice with customers out there in the wild, seeing real, ROI and real calculatable results. So with that, I'm going to turn it over to Ethan. Ethan, are you able to hop on and share your screen and maybe introduce yourself for a second?
Sure. Hi, folks. It's nice to be here with you all. And let me just share my screen and I can walk you guys through a demo. While I'm pulling this up, I can give you guys a little bit of background. Make sure I can get this page up. Can you guys see my screen?
We can.
Yes.
Yep.
Well, yeah, so it's nice to meet you all. I'm one of the co-founders of GenHealth. Like Ricky mentioned, my background is mainly in software and data engineering with some machine learning over the past couple of years as we've been building our models. Before GenHealth, I worked with Ricky quite closely at OneUp, and before that was working at a cancer hospital in Boston at Dana-Farber, where I helped them build their clinical trial matching platform and do a number of other integrations. So it's great to be here, and I'll just walk you guys through a little bit of what we've built. So just to give you guys a sense of what you're looking at, this screen is designed to be used by a team at a payer. So this would be a nurse reviewer, it could be a medical director, or it could be an intake specialist that is being tasked with reviewing a number of different auths that have been received. So these could be prior authorizations, these could be inpatient reviews, they could be retrospective reviews, they could be any form of review that requires a clinician of some kind to adjudicate a patient record against some kind of medical policy or non-clinical policy. So what each row here represents is the output from our adjudication engine, where we've processed whatever the input data might be. I saw there was a question earlier about input formats. We can process PDF reports that are received via fax or email, transcripts from phone calls, electronically submitted via email even, or direct FHIR bundles from an EHR, or any combination thereof. We then extract all of the relevant information, match it to a corresponding policy, and then output a recommendation. So I'll show you guys a little bit what that looks like here. And just before getting into the details, I'm just going to pull up some of what these original documents might look like, just to give a sense of kind of what process we're trying to improve. So on the left-hand side, you can see a kind of simulated example of a patient record that in this case might be received either as an attachment to a portal submission or via fax. And on the right-hand side, we have a medical policy. So these are generally publicly available policies that we've scraped from different payer websites on the internet. So this one is from Anthem, and this one is just about gastric bypass. And so there's a number of criteria here that the team would need to verify is present in the patient's chart in order to approve this case. So, is the individual 18 or older? Is the surgery one of the 5 following options? Is the BMI 40 or greater, etc.? And so what we've done is we've tried to make this process much, much simpler to review by answering each question on its own, like Ricky was mentioning earlier, and highlighting the location in the document where there is justification for the answer. And so these are drafts. So these are not intended to be final answers, but they are the first reviews or first cuts that can be highlighted for a reviewer or an intake specialist to take a look at. So they're designed to be able to be easily overridden. So it turns out actually this patient's birthday in 1980 or 1981, you can update the values here and also look at a top level recommendation about, does this patient meet medical necessity requirements, sort of yes or no. And that's most of what I wanted to show you all here on this screen, which is more related to the actual adjudication. But there's a couple of other pieces that I do want to highlight as well. So besides just individual adjudication, what we also have is a large library of medical policies. So Ricky was mentioning this earlier. They have many from CMS, but there are many other publicly available policies from Humana and Anthem and Oscar, where we've been able to scrape these from the internet, just open. There's no like impersonation going on. These are public documents where, oops, this PDF is not quite available, but we do have the actual content from the PDF here, where we've also output a decision tree, which is based on the content of this particular policy. And these decision trees can be easily updated. So these are the questions that we will ask every time a patient's case is received and matched to this policy. And these particular questions can be updated very simply. So sorry, excuse me. If there's an error with the way that our systems have generated these questions, or there are different questions that are unique to the particular team, they can be added here or removed quite easily. So we can add a question, we can remove it, we can add different kinds of answers. And this is a very simple process to manage a large library of these kinds of policies. So this also applies not just to medical policies, but also to non-clinical policies. And these are rules that we found are typically not as easily accessible publicly. And just to give an example, these rules might be ones related to, if a auth is received from hospital A for procedure B or from provider C, automatically approve. Like this auth does not require prior authorization review at all and just should be either bounced back, and you can say you actually didn't have to submit this at all, provider or hospital, or automatically approve. And we also have a process to encode these kinds of rules into different policies. And this is actually a lot of the work that we've been doing with GuideHealth. So there's been a number of different rules that GuideHealth has shared with us, and we've been transforming them into these kinds of decision trees that you see here. And so these are just an example of what the flow might look like. Is this procedure performed by a specialist? Is the specialist at one of the approved facilities? Are medical guidelines met? Yes or no? And this tree is what our AI system can follow as it's trying to figure out whether or not a patient meets a kind of, let's just say the guidelines and rules that are in place to guarantee an approval. And so what I can share with you guys here is I'll pull up just an example of a report that we can generate for auditing. So once we do reach a decision, can we justify the decision with kind of a very detailed view of why we reached the decision that we did? So let me just share an example report here. So this report that you're looking at is a redacted example of an auth that we are processing, where we've pulled out a number of different discrete pieces of information from the provider portal submission. So all of this is not generated. This is just recreated from what the providers submit. And then there's a number of different codes that are requested. There's diagnoses. And what we've done is from the uploaded attachments, so in this case, there's a 58-year-old male with a history of lumbar problems. We created a clinical summary. We've summarized what the actual documents that have been uploaded are. And we've run through the decision-making process that I was just sharing a moment earlier. So the decision tree that you were looking at, each one of those questions is now rendered here in a step where we can say, is this request a consult? Yes or no. No, the request is for a procedure. Our citation is that there is a CPT code from the provider portal that does not describe a consult, describe the procedure. Second, is this a pain procedure? No, this is not a pain procedure. Is this in network? No, we look up this ID and can show it's not in network. And finally, we can look here at the medical necessity criteria. Has this patient met medical necessity? Yes or no? And we can wrap all this up into kind of a final decision recommendation where in some cases we can't make one. It's just not possible to definitively approve or deny. And we recommend to escalate for RM review because of the following reasons here. So this is just a kind of a snapshot of the process that we're working with GuideHealth on improving for them, and the kind of different sorts of outputs and inputs that we use to reach these decisions. So producing one of these reports from a set of patient data, could be a 10-page uploaded document from a provider portal, or 30 pages generally is maybe 30 seconds to a minute. And we can run hundreds of these in an hour, probably thousands if we needed to. We really haven't gotten there yet. And I think I'm just about out of time. So I will pause here and see Ricky.
One more point to add is like the reason why we are also displaying or rendering this PDF view is because a lot of the prior auths and transactions today in healthcare are still through fax. And we find that change management is easier to manage if we just slipstream additional pages in through the fax, like Ethan just showed you. And that renders the rest of the workflow exactly the same at organizations. So they can get the benefits of the decision without necessarily having to use a different application or workflow or any of that stuff. Obviously, there's clear benefits in using the application too with links and all that, but we understand that it takes time to change over a whole lot of business logic. So I also wanted to spend just a second to let Sanjay Dadamani introduce himself. He's the CEO of GuideHealth, who's working with us on this as a customer. And then, Sanjay, do you want to say just a couple words to share with people what you do?
Happy to. Unfortunately, I'm on the road. For us, we deal with prior auths and applications for both the providers in terms of access. And so having a solution that can improve the efficiency in the process, actually give a lot of time to clinical professional review and have oversight. Important opportunity, and it really drives down to some of the clinical guidance that you've been able to from the plan perspective. So early days, but so far so good.
Sanjay, I sure hope you are in a parked car.
Parked car.
Oh, good. Thank you so much. Gosh, the chat has been lit up, and Ethan, you were able to answer some of the earlier questions. I might give you a chance to respond to a few of those questions that are out there, and then for those that we would like, we'll take some live in a moment. I do have a couple questions before, as Ethan's catching up on the task. I was very interested in hearing about your, if you have a denial, to be able to simulate, what's the recommendations on, the follow-up. Gosh, we can't approve this, but you should do something else. Is that using a decision type of a software like an MCG or Interqual to provide that, or is that learned information? Where are you getting that information?
Yes, so that's information that is been trained through our large medical model. So we have our own AI that has been trained on about 140 million patients worth of claims data. So, going back decades of histories in certain cases. So it has every procedure, medication, uh, what provider they saw, what their demographics are, how much did that care cost, what their conditions are, et cetera. So that model, just like language models, has learned what happens next in a sequence of events. It just so happens that our events are medical events and not words or parts of words. So we are able to use that model to take in a patient's history, tack on, you know, yes, having this procedure, no, not having this procedure, and then play out that future. Just like you would in a language model, do something like the dog is big and blank. It may say fluffy, slobbery, hairy, whatever it might be. Or, the cat is big and blank, you know, a really ferocious tiger, a lion, whatever it might be. So you can do that same thing with healthcare records. And we're finding that that's uncovering new science, like new relationships in the data that have not been published before, but are being validated by clinicians and people in the medical field, along with research as well.
It sounds so complicated by looking at claim data to actually have like a timeline of claims, based on this particular condition, tying the downstream claims together and then normalizing that so that you can compare to other timeline streams. What kind of challenges did you have there in normalizing that data?
Yeah, I mean, I wouldn't say that was an easy uh, task. It's probably like, the majority of the challenge here at GenHealth is, you know, dealing with a lot of data and compute. But what we're finding is that now that we've done that, we're really able to accommodate many different data formats. So, and that's gets to kind of Janice's question. And hey, Janice, good to see you again. Um, why are we using PDFs? Like, what about FHIR, right? Like, I spent 8 really difficult years transforming with Ethan, transforming dozens of health plans data to FHIR. But the reality is that there's so much more information that is outside the FHIR resources that are necessary, that don't have particular locations in FHIR that are consistent enough in order to use that data to adjudicate prior auth decisions. So yes, FHIR data is helpful, but you still need that complete patient record. And we haven't seen it come in through the structured FHIR fields. It could probably come in through like the FHIR binaries or things like that, but it would end up still being some sort of PDF or other text-based document.
Ricky, I was going to ask this question. This comes from Co-Medium. How are you evaluating the performance of your AI outputs? Can you share metrics on accuracy? And it's probably from both sides, right? From the recommendation side, but also for the, the recommendations for denial in the processes that you have. How accurate is that? And then as well as actually the, approve or deny that side. We have, two different
Yeah,
sides.
maybe I'll let Ethan answer that one.
I'm sorry, could you repeat the question? I
Yeah,
was trying.
how are we evaluating our prior auth adjudication approach?
Got it. So we primarily use the existing human team's decisions as our ground truth. So, for example, if a human team has reached an approval for a case, we measure our accuracy as, did our AI model also reach an approval? And generally, we found that without any tuning or fine tuning, we're around 80 to 85% concordant just off the bat. And after a brief, usually pretty brief period of tuning where we can process, 1 to 200 cases with known outcomes, we can get to about 90 to 95% accurate to existing human teams. And this is very configurable because the teams that operate now have different ways of interpreting sometimes somewhat ambiguous guidelines. So I'll just give an example. A lot of the guidelines that we are looking at related to hip or knee or wrist surgeries have verbiage, which is something like, has the patient received optimal medical management? And that's a bit ambiguous. What does optimal medical management? Is like 6 weeks of PT optimal, 8 weeks, 4 weeks? Is NSAIDs are part of? So these are sort of clinical questions which may not have absolute answers. And tweaking those individual questions and tweaking them so that they match whatever the human teams are already doing is a lot of what we work on, like day to day. Making sure that we're meeting, because that's really what we're trying to do best, is like automate the existing workflows and existing processes of these teams.
Yeah. Ethan and Ricky, are you, I think, Ricky, when we spoke before, it was more about making recommendations to the medical reviewer as opposed to responding in real time to the PAS. Are you, what's the balance there? Are you turn that automatic approval on, or is it all that recommendation side?
So yeah, so we think about this. You guys can think about this maybe as like the same sort of ideas around driverless cars, right? Like there are maps which are just informing you. Then there's Google Maps, which is recommending a path. And then there's autonomous driving, which is making that decision and turning the wheel and going that direction. So where we are with GenHealth is we're in the inform and recommend. We are not yet making that decision, although we can. Organizations do want us actually to make the decision to approve, or when it's an approved, to like just go ahead and approve it without having that nurse review. But pretty much universally, everyone wants to review on the denials, which we think makes sense as well. So our model can't, and I think like we have to recognize humans make errors as well. Our model could be put into place where it just made the decision, but we think that at least right now, it is definitely something that people should review themselves. And I think as more and more people use it, as they improve, more and more trust will be gained, and ultimately you'll be like, hey, yeah, it just makes sense for the model to do it. One other point on that is that in our evaluations, we do see a lot of variability in the human reviewers, and the models can be run or tuned in such a way that they're very consistent run after run. And that's a level of consistency you don't really get from the human reviewers. So it is providing some added benefit beyond just like the automation from a quality perspective.
Okay. But I just want to make a note. Please look at the chat. It's really active and has some really great questions and answers. So I'm going to start reading. Oh, Dennis, you just had an answer from Ethan. I was going to ask this question that you just typed in. Tell you what, Ethan, rather than you answering every question starting now, I'll start asking the question verbally to save your fingers, right? So you don't have to type it.
Sure.
Dennis, asked a question. Let me see here. I just lost it. Is there a need for a PA backend workflows tied to the CRD endpoints? So I think she's trying to tie the requirements for prior authorization to the actual PAS decision process. I know back in the day when we didn't have CRD, there was a lot of back and forth questioning. Please send this, now send this one too, and send this one too. And there's a lot of conditional type logics. If I see this in the attachment, we'll ask for some more. Any sort of back and forth have you discovered in those questions? And that kind of relates a little
Yes.
bit.
So basically, like the FHIR spec, requires both the document template discovery and the CRD part of it, and there is a back and forth there. Like first, the provider organization needs to understand, is prior auth required for this CPT or this procedure? So that is something that we do because we have to have, we've read all these policies with our AIs. They have extracted from them the medical codes, the CPTs associated with them. And we have a lookup service so that you can just hit it with an API to understand whether or not that's required. And after that response is provided back, then the provider has the opportunity to submit the patient's to request the questionnaire or the questions that are required to be answered, which are the extracted decision tree questions that Ethan was showing. So that gets sent back, and then the provider has the option of either manually filling those out, or what we think is likely going to happen broadly, which is they're just going to want to submit the full patient chart and have the AI at least take the first pass. And our technology has the ability to just provide you with the decision, the interim decision before the human reviewer, and identify, hey, this question was not answered and it was part of the required, part of the decision tree, and therefore, highlight it for you or tell you that it's likely to be denied before you actually submit, which allows the provider to, modify that and then do the submission. And I think what we're going to see is that that's going to dramatically reduce the back and forth time, which is typically like 2 weeks to, get a response. And that's really what the government is intending here. They, for timeliness to get care.
Okay. Here's a question. Have you tested your outputs broken down by demographic subpopulation to test for potential bias?
So we have tested our model on that, and we have published a paper around our model that explains that in detail. And the summary is the more data that exists about a population, the better the model works for that population, the lower the error rate, which makes sense. But that naturally does mean that underrepresented populations will have a higher error rate. And what do you do with that? Like, do you, what we're doing is basically informing the public about the performance, which is what we think is like the best outcome. But we don't think it would be right to, let's just say use less data for everyone else just to give everyone, an equally, less performant model. We would rather, over time amass more information so that it improves for everyone.
Thank you. I have a question from Mary Kay McDaniel. Mary Kay, I miss you. It's been a long time. How do you maintain all the policies over time and how they are applied to the model?
Yeah, I can answer this one. So we have a weekly scraping mechanism that goes and checks all the policies that are publicly listed. If there's one that's new, we archive the old one version and then put the new one up. This is most applicable, by the way, for the CMS policies we found. And CMS actually is quite good. They have an API, they have a what's new and what's updated. And of almost all the orgs that we've scraped, which is now probably 40 or 50, CMS is by far, I think, the easiest, which was surprising to us, but maybe not surprising to you all. And yeah, that's how we do it.
Ethan, when we first got started looking at the proposed interoperability and prior auth rule, and then as we were providing feedback to CMS as well as talking to folks that are implementing it, one of the things that we heard was the hardest for a payer was just to get all those policies digitized. Identify they're in multiple sources. They were not necessarily in electronic form, and you mentioned you have a library of a bunch of different policies that you've already digitized into sort of a workflow sort of a thing. When you have a new customer that's a payer, it'd be really interesting in your experiences and actually working with that payer to accomplish that and getting that into your product.
Yeah, actually, that's a lot of the work that we've been doing with Guide Health. Guide Health had sent to us a large corpus of documents that their team uses to adjudicate. And like you're saying, it's very broad and wide ranging. So there are some custom medical policies. There are other rules that exist in maybe Word documents that are turned into PDFs. There are different versions floating around. And I think it's just getting all of those docs in one place, I think, was a helpful exercise for the team to just know, okay, if we need to adjudicate, a CAT scan or CT scan, what do we actually have to look at? What's the most recent document internally? And turning it into a structured rule, which is kind of what we're doing, was the step two. And kind of automating is the step three. So I think that's probably something very common among many of these teams where, especially as folks maybe come and go, or there are changes to policies or updates, that this can get quite messy. And so that's a lot of what we're trying to help clean up, with, especially with AI, is we can do it a lot more quickly and pretty cleanly.
Yeah, like one additional point to make there is that it humans we do not require humans to go and read through a policy and figure out the logic and then enter it into some form with a yes, no, this, that answer, or build that logical, uh, diagram that Ethan was showing you. Instead, all we need is basically to be pointed to the corpuses of policies in text form. And we take that text, we run it through the AI, and the AI structures it as a computable resource. And that computable resource can then be presented as like a FHIR questionnaire, but it is what is powering the logic behind the scenes in our model.
So a
So
little bit like a generative AI sort of tool, if you
yeah,
will.
exactly. So like all we need is the source material. We put the AI on top of it. It turns it into the structure, and that that piece really takes like just a few hours, really.
Interesting. Wow, that's kind of cool. Nachi, hopefully we answered your question on that last best round. I am interested from a payer perspective. There's going to be, are the payers pushing out the forums to actually fill in the PDFs, or are they getting the PDFs, or sometimes it's submitted through FHIR resources, or they're coming in through, you know, you know,
Yeah,
from what I'm saying? It's, how do you normalize that? Or do you?
Yeah, I guess
yeah.
that's a good question. I guess before getting into it, just one sort of thought about, I guess, the DTR piece and the Da Vinci spec, which is kind of related to what you're asking, which is, a lot of these policies have very complicated criteria where you need to know very specific information about a patient's lab value or their previous medical history. And if you wanted to do that with only the spec as it exists today, every EHR and every payer would have to go through a very detailed mapping exercise where for every policy, you would need to map to a discrete field in the EHR that would probably change over time for hundreds and hundreds of these policies. And to us, as we started to kind of dig into this problem, that didn't seem tractable, or just like there's just a better way to do it than to try and spend all this time mapping, which actually we had done a version of at OneUp where we mapped just claims data to the FHIR standard, not even sort of for matchmaking, just to actually get it in. And that itself was extremely difficult, like way more difficult than we thought. So this is like even harder, right? Because this is not just mapping to conform to a standard, it's mapping to conform to a standard to use in a decision-making process. And so that's a little bit of why we took this approach, where the AI cannot do everything end to end completely touchless yet, but it can get you 85, maybe 90% of the way there for a majority of the cases, and especially for simple approvals or cases where an auth wasn't even required to be sent. That in itself can free up a huge amount of time on these teams, and is why we wanted to approach this really from like an AI first perspective. Like, how could we rethink the way we do this with like a new technology instead of trying to shoehorn completely into the old? So we still use the old. We can definitely still integrate, but that's a little bit of the background of how we're thinking about it.
Okay, interesting. So I want another question. And by the way, you're keeping up with the chat really well, Ethan. So if we're not answering your question through chat, please say you didn't answer your question, ask it live, and we will. Well, here's one from Sarah. Are you using hospital machine readable files? Ooh, for price transparency in your analysis.
So we actually have, I would say, something better, which is, the issue with the hospital price transparency files are that they are what the they're like the sticker price. They're not the actual price, and oftentimes they're very inflated from what is actually being paid out. And what is being paid out is also very different by plan and by case. What we have is we have real data on over 100 million patients, billions of transactions that include the actual dollar amounts that were paid out, were paid to the provider, were paid by the patient, paid from the payer, et cetera. And we have that trained in through our model. So that is available through our model. Um, so yeah, it's a little different from the price transparency list, but this I would say is the true price.
Okay. I have something that we had presented, golly, it must have been 10 to 12 years ago. A large health plan presented at WEDI, and they talked about automating their 278s. And what they did was they put in a lot of business rules. We just know when they ask for this kind of a prior authorization and they submit, this attachment, we are going to go ahead and automatically approve it real time. And I know another one that actually presented several years ago at a WEDI conference mentioned that they just build in a lot of just knows up front in their process. They're including that in their PAS process. Are you inserting your logic after that logic, or are you including some of that just no logic in yours?
So yeah, a lot of that yes no logic is included in let's just call it the
Or the
business
workflow?
rules
Okay.
that Ethan had showed before. And it depends, some organizations have a much more complex set of those. Some do not, and they don't do any sort of gold carding or any kind of special treatment there. But our solution does have a place for those sorts of rules. And I think, like, one other point to mention is that this, even though, we built a lot, we have like great kind of ROI numbers, a lot of this space is still very early, and we are still looking for, more folks to collaborate with in this space, especially if you're kind of sitting between the payer and the provider, or if you are a payer and you know a provider that wants to work with you on this, or vice versa, because that's really what this is all about, right? Like, we don't want to just do this only for the plans or do this only for the providers. We really want to use this as a mechanism to enable a much more seamless transaction that ultimately helps the outcomes for the individuals. And I think they're, like we were showing you earlier, it is really a win-win-win situation, more than just like the administrative burden piece on both sides. There's actual economic outcomes from the better care and the expeditious nature with which it can happen.
Um, here's one from Janice. Ethan, you missed this one. Is your training data, does it, if your training data goes back that far, how do you account for changes in best clinical practices that occurred over time? The correct treatment for X in 1980 is different from the correct treatment now. You
Yeah,
can't, right?
yeah. Our model has a time token, so we can, you can tell it's like 2022, and it will give you different events and costs than if you told it was 2014 or whatever.
Okay, cool. Hey, as an old time technician that's retired now, it's just, and being involved with WEDI for so many years, it's so rewarding to see healthcare move towards, more automation, learning, trying to treat the patient in the best way possible, minimizing costs and all that. It's just really rewarding to see this kind of a technology being applied out there. So keep it up, guys. It's really awesome. And I hope everyone who attended today got something out of it. Um, uh, and Ricky, I'm sure you might be hearing from Michael McNutt about possibly speaking at one of our conferences. You guys are really, really good today.
Yeah, no, we really enjoyed being here. Thank you for inviting us, Ed. And yeah, I just posted our emails in case anyone wants to get in touch later or collaborate
great.
on this in the future.
All right. Well, thank you so much, guys. And thank you, everybody, for attending today. Great session.
Yep. See you
Thanks, everyone.
guys.
See you.